Mm. Hello, Mustafa.
Hello, doctor. How are you?
I'm good. How are you?
Thank you, doctor. I'm fine.
I don't know. Why are there only 10 people today?
It is a bit earlier, I think.
Hmm?
Because doctor, there was a usual time is the 7 o'clock Pakistani. I think everyone else
Okay. So, what do you want to guys do?
because many are unaware of this timing.
Okay. So, let's. Okay. So, if it's okay with you, let's do 7 o'clock then.
No, doctor, it's okay for me even this time, but I think the usual
Okay.
time is seven o'clock Pakistani. So that's why I think
Okay.
most people don't know.
Okay. We'll wait. Yeah. I will wait 10 more minutes and let's see if people join. Yeah.
Hello,
Because.
doctor. I have an opinion. If you are agree, everyone agree. If you have a patience and you can explain the cystic fibrosis until they join, everyone join.
Can you repeat it again? Sorry, I didn't get your question.
So I said that if everyone are agree and also you are agree, we can revise the cystic fibrosis. It is a little bit high yield topic
Okay.
until everyone join.
I had a question.
Yes, yes, yes.
Are I've joined after a few days, so can I please know, are we still doing pulmonology?
No, we are done with pulmonology. We were doing immunology.
All right. So I'm still
Mm.
doing pulmonology, but I couldn't find the lectures where you had explained all the things because I personally find your lectures very like they are very
Mm.
I'm able to understand things very well. So is there like have you explained pulmonology to a previous batch or something like if we have any recorded videos of you?
Uh, Not to the previous. What I could do is that I could record some videos and I could send them. I wasn't able to do pulmonology, because I was in the ICU. I'm still having ICU rotations, and these are night rotations. So it was hard for me to first adapt and do it, but now I somehow find time when I come home to do 1 hour of it. So yeah, when these shifts end, right, I'll do a pulmonology session with you guys, don't
That
worry.
would be so kind of you. Thank you so
Yeah,
much. So
you're
we are doing
welcome.
immunology right now.
Yes, we are doing immunology.
Okay.
Okay, so the first thing that is very important is the failure to thrive. What does this thing mean, right? So wherever you whenever you like go into whenever you solve a question, they are gonna give you one keyword, right? And that one keyword is gonna be very important, right? There are different keywords, there are different presenting complaints, right? One complaint would be chest pain. Okay. I'm just telling you like general things, right? So, for example, a patient can come and they can say that a patient came to you and that patient has chest pain, right? It starts from here. Okay. Now, if they say that if a person is having chest pain, all of a sudden certain things should come into your mind, like myocardial infarction, acute coronary syndrome, aortic dissection, aortic aneurysm, pulmonary embolism, pneumothorax, pneumomediastinum, and all of these. And then you're gonna ask, what should I look into the question, right? Don't let the question make you think about things, right? Make you think about the question, right? When you have grip over the questions, things are going to be easier, right? If you don't have grip over the questions, if the questions control you, things are going to be very hard.
Very tricky.
right? So basically, keep this in mind, right? So coming back to cystic fibrosis, right? The first thing regarding cystic fibrosis that is the most important is that we are gonna give you a patient who is gonna have failure to thrive, right? Right? They are gonna have failure to thrive, right? Now, second thing is that they are gonna have recurrent infections, right? They are gonna have recurrent infections, right? So basically, they are gonna give you a patient who's gonna have recurrent infections, who's gonna have failure to thrive, who's gonna have infertility, right? And I like to, what do I want to do is that I want to tell you about syndromes by explaining the pathophys, right? So let's go over the pathophys of cystic fibrosis, right? So there is a gene which is known as the CFTR gene, right? This is the gene that is problematic in cystic fibrosis, right? When this gene does not work anymore, whenever there is whenever there's mutation of this gene, right? What is gonna happen is that chloride channels are gonna be absent, right? First thing is that chloride channels are gonna be absent. Now, what is important is that whenever these chloride channels are going to be absent, these chloride channels do two things. First thing is that in sweat glands, right? Remember this pathophysiology, right? Remember one thing is they're gonna do in sweat glands, it's gonna absorb. So if this is the sweat gland, right, it's gonna absorb the chloride back, right? So for example, if this is your sweat gland and if this sweat gland secretes a lot of sodium outwards, right? So for example, you are playing, right? You are playing, right?
Doctor,
So
I'm sorry. I don't know if you're sharing your screen, but we are not able to see it.
oh my god. Oops, sorry. Okay. So if this is a sweat gland and this is the blood vessel and above the blood vessel is the skin, the sweat gland is going to is going to secrete all of the sodium here in the screen, here, right? It's going to secrete every single thing here, right? So basically, this is what is going to happen. It's going to secrete water with sodium chloride. Now, what is the sweat gland? What is the sodium channel going to do? The chloride channel, it's going to reabsorb the chloride. And when the chloride is going to be reabsorbed, sodium cannot remain without chloride. The sodium is going to be reabsorbed as well. Okay, so this is the first thing it's gonna do. So let me ask you, if a person is having cystic fibrosis, and if someone tastes the patient sweat, what will it be less salty or more salty? Like you wanna do an electrolyte test of the salt of that patient. More salt.
More
Yes.
salty.
So the salt is gonna increase. Now this is where the problem comes in, right? Because people are going to think the same is going to happen in everywhere else, right? So remember, I told you chloride is followed by sodium, right? And sodium is followed by water, right? So sodium and chloride are going to be reabsorbed and they are going to be followed by water. Okay, so this is the first thing that is going to happen. Yes, Mariam. Yes,
Sorry,
Mariam.
it's just incidentally raised. Sorry.
Okay, it's okay. No worries. Now, water is going to follow. So now comes the second part of the problem. This is the GI tract, right? There are glands, and glands secrete water, right? Glands secrete sodium and chloride. So this is the GI tract. Gland is going to secrete everything here. If this is the gland, it's going to secrete everything into its lumen, right? Now, it is going to secrete everything into the lumen, right? Everything is going to be secreted into the lumen, right? Now, when everything gets secreted into the lumen, right? The chloride is going to be secreted into the lumen, right? What is going to happen is that if the chloride channel is defected, right? The chloride won't be secreted into the lumen, right? So now I'm going to ask you, if chloride is not getting secreted into the lumen, right? Will sodium get secreted into the lumen?
No.
No.
No. Okay, I want you to be clear on this, right? Now the chloride is going to be secreted into the lumen, right? And then sodium is going to follow it, right? Sodium is going to follow it, and then water is going to follow it. All these three things are going to be together, right? They are going to follow it. Okay. So now, if the chloride is not present, the water is not going to be present, right? And what do you think will happen to the secretions of the gland? Will it become more mucoid? Will they become more thick or less thick?
More thick.
Yes. So is everyone clear on this? What is happening to the secretions of the glands everywhere in the body except the sweat gland? So no chloride is going to come, no water is going to come. The secretions are going to be very thick. So the secretions is going to be so much thick that it's going to block the lumen, right? And when the lumen is going to be blocked, nothing is going to come out of it. So this is the pathophysiology of what do you call it? Mm, cystic fibrosis. Now let's explain the symptoms one by one. The main thing that provides energy to the body is fats, right? How are the fats absorbed? With the help of pancreas, right? And pancreas is going to secrete what? Lipase. If the lumen is blocked, okay, the lipase. So if it is blocked, lipase is not going to get secreted, right? And when lipase is not going to get secreted, right? Then what is going to happen is that uh, when lipase is not going to secrete it, there's not going to be no absorption of fats, there's going to be no digestion, and you're going to get failure to thrive, right? Similarly, second thing is that uh, if you have the testes, right? On the testes, there's going to be a thing which is known as the vas deferens. Again, there is going to be secretion, and this secretion is going to block the testis outlet. When the testicular outlet is going to be blocked, you're going to have infertility. Okay. Similarly, pancreas are going to secrete insulin, but if the duct is blocked that secretes insulin, you're going to have diabetes, right? Similarly, in respiratory system, this tube is going to get blocked with the help of the secretions. When the tube gets blocked, respiratory infections is going to happen here. When there are going to be infections, the bronchi are going to get dilated, right? They're going to get dilated, right? Is that clear? And that's going to cause bronchiectasis.
Yes, clear.
Okay. So now what is going to happen is that this is you're going to have COPD with bronchiectasis, and basically this is what you are going to have, and then you're going to have salty sweat, right? So, and you're going to have infertility and all of those things. So basically, this is the pathophysiology of cystic fibrosis. They're not going to ask you about the treatment. They're just going to focus on the pathophysiology. Okay. And then it's the problem of CFTR gene that is present on the chromosome 7, right? Okay. Any other questions? If not, I'm gonna move forward to the transplant rejection thing. Okay. So first of all, we are going to transplant rejection. So what is a transplant? So we do transplant in order to save, like we are going to do transplant, right? Um, in order to like save an organ, or if an organ does not work anymore, we want to work, we just transplant that organ. So whenever we transplant an organ, certain things can happen. The first most important thing is that s- the first most important thing is that, for example, it's that if you have antibody, if you transplant an organ, right? So remember, every organ has its okay. If you transplant an organ, right? Mm. Okay, I think this is big enough. Okay. So if you transplant an organ, what is going to happen is that there are going to be antigens on the transplants. Every cell of ours is marked with antigens. Antigens are thing that defines what the cell does. Like antigens are the cell that decide, right? Antigens are the cell that decide what do we do. Okay. So what is going to happen is that there is going to be antigens. Sometimes what happens is that there are going to be preformed antibodies in the host cells against. So for example, for example, we have a person named X, and we take his kidney and we give the kidney to Y, right? But Y already has antibodies against his kidneys, right? So what is going to happen is that as soon as we transplant the kidney to the patient is going to get a lot of bad symptoms, right? He's going to get hyperacute transplant rejection within minutes, right? Because preformed antibodies are present. Okay. It's just like it's just like you have a dog in your home already, right? And you bring a cat from outside, right? What is going to happen? The cat dog is going to eat the cat, right? You have a preformed dog that is present in the home, and that dog is going to kill the cat, right? So this is what happens, right? Similarly, so this is important, right? Similarly, remember, so dog is going to eat the cat, and then there are going to be problems. Okay. Now, second thing is that this is hyperacute rejection. So antibodies are going to attack, right? And remember, whenever antibodies attack against something, what kind of a reaction is it?
Type 2 hypersensitivity
Yes,
reaction.
it's type 2 hypersensitivity reaction. Okay. It's going to be a type 2 hypersensitivity reaction. Now, next thing is that what is the what is the pathophysiology? Like what is the histology that is going to be present, right? So what happens is that the antibodies attack the the graft, right? And especially it causes ischemia in the vessels, right? So it causes rapid ischemia and it's gonna cause thrombosis of the vessel. Okay. So you are gonna have thrombosis that it's gonna be present immediately, right? So you are gonna have immediate thrombosis of the vessels, right? So whenever they give you a question, they say, and they don't tell you about the time. The first most important thing is that they could tell you about the time. If they say that if an organ was transplanted and now the patient is having problems, and you see how long was the organ transplanted before, and the organ was transplanted just minutes before, then it's a thrombosis. But if they don't give you a time and they say there is thrombosis of the vessels, then again it's gonna be a hyperacute transplant. Then we go on to move towards the next transplant, which is the acute transplant rejection. Okay. The next one is the acute transplant rejection. So what is important in the acute transplant rejection? So what happens is that after some weeks or months, right? You now the T cells are gonna be activated, right? T cells are slow reacting, right? Okay. Now T cells are going to be slow to respond. So if the body gets to something from outside, right, and the T cells are going to get activated soon, right? I'm going to tell you more about T cells later and how do this work, right? So T cells are going to activate, right, and then the T cells are going to activate. What is going to happen is that it's going to cause inflammation, right? Right. So T cells are going to be activated. T cells are going to cause vasculitis, right? Right, it's gonna cause vasculitis and like T cells are gonna cause a lot of damage, right? Now the important thing regarding T cells is that T cells are inflammatory cells, right? They're inflammatory cells, right? So you are gonna see interstitial infiltrates, right? You are gonna see interstitial infiltrates that is gonna be present in case of uh, acute transplant rejection, right? They are going to mention in the question that the patient is having acute transplant rejection, right? So remember, they are going to ask you about the prevention as well. Like, how do you prevent these things? And we'll go over in detail. So, if you have a preformed antibody, how do you think you can prevent that? How can you prevent that kind of a transplant rejection?
Suppress the host immune response.
Hmm. No, no, no. The acute transplant rejection, hyperacute transplant rejection.
By removing the antigen causing the antibody response.
Hmm. Okay. Any other thing? Mm-hmm.
The graft should be removed.
So basically, what do we do is that we do cross matching. So the thing which is cross matching is thus for hyperacute transplant rejection, right? They're gonna ask you this question a lot, right? That we did cross matching, and what did we do was that we just took so what did we do is that we took a graft and we tried to do cross matching, and that is why we try to take grafts from family, right? Right. So we try to take the grafts from family, and when we take the grafts from family, that helps a lot. Right. Right. That's help a lot. So we try to
Doctor,
take the
doctor,
yes.
can you please repeat this concept about hyperacute? I can't get uh, cross matching.
Okay,
What
so
is?
yeah, I'll tell you. So let me tell you, right? Mm, Our body is sensitive against something, right? Our body is very sensitive against something, right? Like let me I don't know. Like I first came to know like the people who are joining from US, they would maybe I don't know. There is a cake which is known as a white trash cake. Okay. So there's a cake, white trash, right? So a patient came and apparently he had a white trash cake, right? And in white trash cake there are peanuts, right? So he was allergic to peanuts, right? Type 10, type 1 hypersensitivity reaction. And it was the day after I taught you guys type 1 hypersensitivity reaction. I was like, oh my God. Right. So remember, yet it's a white trash cake. Right? It contains peanuts. Okay. So the thing is, he was so sensitive to allergic, right? Yes. So he was so allergic to peanuts, he just licked his tongue onto that cake and his whole body becomes swollen, right? So our bodies have certain demands. It is very sensitive against certain things, right? So we have to determine it, especially if you are putting in another thing from outside, you have to check it, right? And if you have an if you have a family or friend, right, whose organ is available, obviously your body is going to be more tolerant against that, right? So this is how it happens. So in hyperacute transplant rejection, what happens is that bodies sometimes have antibodies against certain kind of organs, right? All the organs have antigens on them, which are known as the MHC molecules, right? Or different molecules, right? These antigens determine what are they, right? Okay. So like just all of you have a username, right? You have a Facebook username, you have an Instagram username, all of that. You have a bank account number, right? If they put a bank account number on you, every single detail of you is gonna come up. Okay, simple, right? If they put a bank account on you, every single detail of you is gonna come up, right? Similarly, whenever an organ is transplanted or grafted, there have MHC molecules, right? And HLA-B1, HLA type, right? That is gonna show everything, right? So what happens is that sometimes your body is very sensitive against certain types of organs, right? And when your body is certain specific, like very sensitive about those, so if all of a sudden you transplant those organs, what is going to happen is that your body is going to have already made preformed antibodies, right? Maybe you had an exposure to that person during life and you had an antibody, right? So how do we prevent this thing, right? We don't know if you are transplanting an organ that maybe if the body would reject them. It is known as the hyperacute rejection, right? So how do we prevent that? We prevent it in a simple way, right? We take the patient's organ that we're going to transplant, right? And we take the other patient's blood and we mix and match them in an outside environment and we check for any reaction. This is known as cross matching, right? So this is how we prevent type hyperacute rejection. Okay, did you guys get it? Okay. Now we have the acute rejection. In acute rejection, what happens is that the body's the T cells will come, right? And the T cells will be
How
the T
thrombosis
cells.
occurs in, sorry, can I
Yes,
know
yes,
how
yes.
thrombosis occurs in type in hyperacute transplant prevention?
Yeah, sure. Okay. So in case of just wait a second, I'm getting a call. Just a second. Hello. Okay, so basically, let me come there, right? So whenever you are having antibodies against the cells, right? Against the antigen cell, right? So those antibodies are gonna attack the cells, right? It's gonna attack the organ, it's gonna attack the organ cells, right? And there are gonna be blood vessels in them as well, right? And what are the cells of blood vessels? What is blood vessel made from? Anyone? Anyone? What blood vessels? Like what are the blood vessels made from? Anyone? Oh, endothelium, exactly. Right? Antibodies is gonna damage the endothelium, right? And when endothelium gets damaged, it's gonna release molecules, right? It's gonna release. Now it will go back to the same old story of atherosclerosis, but it's gonna be very, very fast, right? Pro-inflammatory molecules are gonna be released, tissue factor is gonna be released, platelets are gonna come, platelets are gonna do coagulation, it's gonna lead to ischemia, right? Is gonna be massive thrombosis. When massive thrombosis is gonna happen, the body is not gonna get its organ is not gonna get enough blood, right? Then it's gonna be infarction, there's gonna be graft failure, right? It happens even before the surgery is finished. Okay, so what do you do is that you do cross matching for it, right? Now let's do another one, acute. In acute, what is going to happen is that again the endothelium is going to be damaged, right? But it's going to happen slowly from weeks to months, right? And remember, for this thing, this thing is going to happen anyway, right? Because T cells are smarter than B cells, right? T cells are smarter than B cells. T cells are gonna attack the T cells are gonna attack the thing anyway, right? Okay, so T cells are gonna attack it anyway, right? And when T cells is gonna attack it, right? Then there's gonna be the vessels are gonna get smaller, right? There's gonna be lymphocytic infiltrate, and the WBCs are gonna come. How do we prevent it? We give immunosuppressants. We give steroids, right? We give steroids. Okay. When we give steroids, the WBC stop working, right? And when the WBC stop working, then you are gonna have the acute transplant rejection. Okay. Now, let's move to the chronic. So remember chronic transplant rejection, right? So remember one more thing. In acute transplant rejection, there is going to be atherosclerosis. In chronic transplant rejection, there's going to be arteriosclerosis. The vessel is going to become very stiff, right? And how does the vessel become stiff, right? The T cells are not going to attack, right? They are going to secrete molecules that is going to cause the vessels to become very, very big, right? It's going to proliferate. When the vessel is going to proliferate, right, then the vessels is going to become very stiff, right? This is the type of transplant rejection that you cannot stop. Whatever you do, guys, this type of transplant rejection is not going to get stopped. Okay, we're not going to do other cell types today, right? Because I think I'm going to have another lecture of the cell types, right? Okay, so remember one two things, right? They could give, these are the two word questions that are very important. The number one is sometimes they're gonna give you a patient and they're gonna say that a patient came to us, right? And when the patient came to us, right, he was being on a lung transplant, right? And after some years, you look at the patient's CT scan, right? Or you look at the patient's anything, and you're gonna see that the bronchioles are missing in this patient. They are gone. The CT scan cannot show any bronchioles, right? And then they're gonna ask you what is the most likely diagnosis. The most likely diagnosis is gonna be bronchiolitis obliterans, right? It is a syndrome which happens in chronic transplant rejection, and what is gonna happen is that basically WBCs are gonna come. They're gonna make the bronchiole wall so thick that it's gonna be completely invisible on CT scan. The same thing happens in case of a bile duct transplant, liver transplant. There's going to be vanishing bile duct syndrome. Okay. 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 Now the next one is graft versus host disease. Right. The next one is graft versus host disease. What happens in graft versus host disease? So all of these diseases that we are studying, what was happening basically was that the recipient antibodies or the recipient cells. So, for example, if I got a transplant, my cells were attacking the transplant cells, right? This is the basic concept of transplant rejection. That my cells or me transplant attack the other person's cells instead of the other way, right? Then sometimes the other happens, right? Sometimes the thing that happens is that the person who are we transplanting into is very, very, very immunocompromised, right? When that person is immunocompromised, right, and the cells that we take from a person are immunocompetent, or the cells that we take are from a healthy person, right, those cells are going to attack our body, right? Those cells are going to attack our body. Okay, so let me tell you an example, right? So for example, a country is very weak, right? What do they do is that they ask foreign investors to come, or people to come into the country. So foreign people do come into the country, but when they come into the country, they literally take everything away, right? They literally take everything away. They start damaging our own country, right? This is known as the example of graft versus host disease. So we insert something into our body, and when we insert something into our body, right, those things are gonna destroy our own body, right? It's more common in people who have had immune problems, right? They are very immunologically weak. So, for example, if a patient is having any kind of blood cancer, right, and he's very low on like WBCs, and you give the patient any kind of drip, right, then obviously there is this syndrome, the graft versus host disease. How does it present? The patient is gonna have diarrhea. The patient is gonna have skin rash, right? The patient is gonna have jaundice. Only these things: rash, skin tone, like skin rash, jaundice, and diarrhea. Okay, so how do we prevent it? In order to prevent it, what do you do is that we do irradiation of the product. So we apply red waves at the product, and the patient is gonna, and the graft versus host disease won't happen. Right? So, guys, we'll keep it till here today, right? After Dr. Hasnain's class, I may take another class, right? I will start. Irradiation destroys the WBCs, the blood cells, right? In this graft versus host disease, cells are gonna attack, right? So, guys, uh, I'm gonna I'm gonna take your time off, right? I'm gonna take some time off, and after Dr. Snell's class, if I will be awake, I think so. I put up an alarm, and then I'll take another class for you as well. Okay, and I'll try to finish things early. Okay, guys, take care. Bye bye.
Hello, can someone hear me?
Yes.
Could you please tell me that about the previous chapter? All of the things are covered already, like hypersensitivities and immunologic blood transfusions, autoantibodies and immunodeficiencies, like complement.
Mm, not following. Really,
I
I've
think
not listened to the
I
previous
think
ones.
Dr. Ahmed has covered hypersensitivity reactions, but not the other ones that you mentioned.
When
Oh,
did he
type
cover?
4 is pending though. Type
I
4
think he
hypersensitivity.
didn't. I think he didn't cover. When did he cover hypersensitivities and uh, cytokines and other? Because I think in his last class he has
He left
done
it on. Yeah, I didn't
uh,
Yes,
follow.
he
Mm.
started.
he's
He
done
started teaching cytokines, but in between there was a break, and then Dr. Hasnain's class was supposed to start. That's what happened last time.
okay. So these topics are remaining.
Yes, I think so.
Okay. I also don't know. I have another question. You all guys are taking a full boot camp course
Yes, yes, most of
because
us.
I'm new in this. I don't know about the pattern. I don't know about the classes. That's why I'm asking.
I think the thing about boot camps is they overlap a lot. So probably you'll be put in the next batch, which will start from new topics. Yeah. So
Okay, okay,
yeah.
okay.
So
But it's
And
good.
you
Like
guys, you guys,
if you are allowed to join these lectures, it's better to join it. It will be like more easy for you to continue with the new marathon. Or yeah.
yeah, that'll add to your understanding. It
you
will not
guys,
be like
you guys have done with 3 or 4 units before.
Lọ kàwé kí ni nǹkan tó ń dé sínsìnyí?
I think we finished. We started
Mm.
with
Oh,
uh
oh, lọ gbé ìwé kó ka àwọn nǹkan tó ti kà yọrí sí
Cardiovascular,
sínsìnyí.
cardiovascular,
yeah,
renal.
cardiovascular. Then we did endocrinology. Then we did renal. Then we did pulmo, and now we are in immunology.
How far it has been? Like 1.5 months.
Sort of, yes.
Okay. And what about Google?
Maybe a lot of
Is it
time.
effective?
I mean, effective is depends on how we study, utilize it.
Okay. No,
These
I'm
are
asking
most
about.
like correct, but from my opinion, uh, these are mostly like guidelines. Like they'll tell you, familiarize you with the topic, but understanding and being able to solve answers and everything is only through self study and practice.
Yes, yes. Because Dr. Hasnan, I attend Dr. Hasnan's last class. I attend, but
Okay, I think this class we're supposed to leave because I think everything is getting recorded. So
okay, okay, okay,
unless we leave,
okay, okay,
people will continue the recording. Yeah. Okay.
okay,
Thank you.
okay, okay.
enyi gị nwoke na adreesị ya ọ bịala ọ ya akụzi ife taa dị ndị nsị gị gaa na rotation